Well, good morning, everybody. I'm Rose Champagne. I'm excited to have Dr. Zubair Shah with us today. He is the assistant professor in the Department of Cardiology at the University of Kansas Medical Center, also the medical director of their mechanical circulatory support program and LVAD program. And he joined that faculty in 2018 after doing his fellowship in advanced heart failure and transplant at the University of Utah. And today we're going to talk about a close topic for me, palliative inotropes, and comparing outcomes between Milrinone and Dobutamine. So thank you, Dr. Shah, for joining us today.
Thank you so much, Rose, for the introduction. And I want to thank you all for this opportunity. I want to thank all of you taking time. I know how busy it is, especially morning time on Fridays. So with that, I don't want to waste any time, go straight into this talk. So we mainly will be talking about a study we recently published few months ago in Journal of Cardiac Failure. The title of the study was Palliative Inotropes in Advanced Heart Failure, comparing outcomes between Milrinone and Dobutamine, as you can see. So briefly into the background, as you all know, data from 2013 showed about 6 million adults in US suffer from heart failure, and estimates indicate by 2030, this would correspond to 8 million patients. At the same time, data also has shown, this is one of the studies from Duke 2020, that 1 in every 5 patients has advanced heart failure. Here, the definition of I want to emphasize is very broad, a lot of overlaps, but in simple terms, advanced heart failure is a state of heart failure where patients are on maximally tolerated GDMT medications and still have active heart failure symptoms, still are hospitalized, still their diuretic requirements are high, or still have on imaging like echo indication of adverse remodeling. The spectrum includes some people include stage D heart failure also in that, where they are out of all the options, would need advanced heart failure therapies. Some include that also. So to summarize, advanced heart failure, very sick patients who are kind of at the end of the road, and the GDMT, the medications are not working anymore. So as I said, 1 in 5% of the patients have advanced heart failure. That in 2013 corresponds to around 300 to 400,000 patients. And one should keep in mind the advanced therapies we offer at LVAD or transplant is around 15,000, 6,000 transplants US does. We do as a country a year. I would say 9,000 VADs, not more than that. So for 300, 400,000 patients, only 15,000 get advanced therapies a year. So as I said, a significant proportion of these patients are not candidates for advanced therapies. And the reasons can be like broad, can be elderly patients, frailty, comorbidities, psychosocial, substance abuse, the list goes on. There is a thought that palliative inotropes, dobutamine and milrinone, can be a feasible option for these patients. But in the broader sense, why we did this study, I will come to the objectives, is, there is so much focus on those 15,000 patients who get advanced therapies. There are like thousands of outcome studies on VAD, on transplant, but I think the bigger group, there is not much emphasis how their outcomes are, what their quality of life is, even the barriers, why they cannot get advanced therapies, how we can overcome these therapies, and so forth. And second interesting point was that the treatment for heart failure has changed. Inotropes were tried in 60s, 70s, and then since then, the combination of the medications, what we call GDMT, the paradigm has changed. So how do inotropes fit there? And is there a role now in these patients? So these were the two broader philosophical questions we were thinking about as our research group. So as I said, there is not much data out there. Even to start with, do inotropes help? Should we offer this this treatment option to these patients? And then are there any difference? How do they do? Not much data out there. And keep in mind, to get that data from different centers or do a prospective study is equally very challenging because of lack of interest, cost of the study, etc. So to summarize, our main objectives where we try to be focused, because study can get very big, the outcomes on these advanced heart failure patients who are not candidates for LVAD or transplant. How are their outcomes when we put them on so-called palliative inotropes? And how is their outcome? How do they do in 6 months to a year? And then secondary aims where is there a difference between the inotrope we choose? Does one group do better than the other group? So briefly we'll go through the methods. It was a chart review retrospective study. It was 2-center study. Our center in Kansas. We also had a friend in South Carolina helped us to include their patients also, and we did chart review 2015 to May of 19, and then looked into 1-year outcomes. So included everyone who was above 18 years of age, qualified for advanced heart failure, and did not qualify for transplant or VAD, which was documented. The reasons were documented. They were evaluated. And also we excluded patients where inotropes were briefly used, but they were selected for VAD transplant. We discharged them as status 4 on these inotropes, or if patients were discharged as comfort measure. So briefly, we included 248 patients in these 4.5 years. And if you see and we divided them in a binary fashion between Milrinone and Dobutamine group. And if you see their baseline demographics, we did not find statistically significant difference between the two groups. So as expected, the mean age of the group was around 65 years with a standard deviation of 13.5 years on both sides, and most of them, as expected, were males. Most of them were Caucasians. Around 47.5% the etiology was ischemic, and half of them were non-ischemics. Briefly, 97%, we were surprised to see patients who we included in the study. 97% already had ICD and CRT-D implanted. 1/3 of patients, as expected, had higher CKD, stage 3 or higher. And we also here found one difference, that dobutamine was preferred over Milrinone in patients who had CKD. So 43.5% of the patients who had CKD were offered dobutamine, discharge on dobutamine, compared to 23.5%. And then all patients had at least one hospitalization in their previous year before this hospitalization, and mean number of hospitalizations were 1.7, indicating this was a sick group we included. Then going into more depth on the meds that they came on when they were hospitalized before they were discharged on inotropes. So as expected, around 70% of these patients, less than 70%, were on beta blockers, dobutamine group, slightly overperforming Milrinone group, but not statistically significant. If you compare ACE inhibitors, ARB, which is part of GDMT, and ARNIs, if you add all of them, around not more than 50%. And then spironolactone also, aldosterone spironolactone being the most popular, around 50%. Most of the patients, which is expected, they have stage D heart failure, came on diuretics, ranging from 86% in dobutamine group to 90% in milrinone group. We also looked into their hemodynamic profile, blood pressure, right heart catheterization numbers. I was expecting we'll find some difference, which will help us to conclude why some patients why milrinone was chosen over dobutamine or vice versa, but could not find a statistically significant difference. Hemodynamic profile kind of appeared similar in these patients, except systemic vascular resistance, SVR, in milrinone group was higher than dobutamine. If you see, it was 2560 compared to 1200, meaning they were peripherally more clammed, had higher afterload, and this could have been one of the reasons. Very difficult to tell, but we didn't see any big evidence PA pressures high by milrinone, as we all think in heart failure community, but we did not find that. It also makes one feel these patients who are not candidates, how much we emphasize choosing between the two inotropes compared to patients who are candidates where we want to bring their PA pressures down. We go for milrinone. I don't know if there is a bias. Once we know they are not candidates, we are not too picky, not too OCD about those things. And then as expected, very sick patients, the mean baseline EF on these patients was 20% plus minus 10%. So indicating they qualified for all advanced therapies. Guidelines say VAD less than 25 transplant, same. So they were very sick and very dilated LVs. Mean LVs end diastolic diameter was 6.1 centimeters, indicating they had very bad LV. So of all of these patients, 248, 118 were referred to hospice service. They were included, but they were followed by hospice service, around 50% of them. But no statistically significant bigger differences between the two groups, which would tell us why one agent was chosen over other, except CKD, as I said. So briefly go through the results on the outcomes. So as expected and as shown in smaller studies, the 1 year mortality of this group was 70%. 70% have died in one group, which is very high. And the median time to death, surprisingly, was 5.9 months. So most of them die in 6 months. But some good news also, although not that encouraging, 10.5% ultimately were weaned off from inotropes in a year and did not require any inotropes. 6 candidates, which is very low number, 6 patients became candidates for advanced therapies, although they were initially declined. They were not sent home with aim to put them on the list again, but somehow things changed. I think they overcame those unknown barriers, which is difficult to find out. 5 for VAD and 1 for transplant. 12% of patients were hospitalized with some sort of arrhythmia. I mean, there's always a question, always a risk we ask when we start these patients on inotropes. Arrhythmia is always a risk we think about. So it was kind of significant, 12%, and a good number, 8.1%, had at least one ICD shock. It's a big number. But having said that, we don't know what their previous arrhythmia rates were and ICD shocks were. Difficult to tell if we can attribute that to their to inotrope use. Again, same summarizing in a table. Total 11.9% patients had arrhythmia. No statistically significant difference. We always think milrinone is less inotropy than is less arrhythmogenic than other one, but did not find that. ICD shocks, as you see, milrinone group had higher, but numbers were low to have a statistical significance. Cardiac arrest, 2% of the patients were admitted to the hospital with cardiac arrest. And as you see, the death, 70% were dead by 1 year. Out of them, 84% in the dobutamine group, and around 58% in the Milrinone group. This was statistically significant and made us go into more depth on this difference. So our next step was when they were discharged once we saw this difference in the outcomes between the two groups, we were slightly excited and tried to find out why is this inotrope itself or these GDMTs, what's going on. We knew on the baseline the groups were not different. They were equally sick. Their hemodynamic profile, echo, everything was equal. Their cardiac output index was low in both groups with no statistical difference. So then we focused on when they were discharged, what medications were they discharged on, and there was a statistical significance there. Beta blocker group Milrinone group, more patients were discharged on beta blockers. If you see this diagram, and I will read out for you guys, 42.4% were discharged on beta blockers compared to dobutamine group, where they were discharged on 8.8, only 8.8% of the patients. ACE-ARB 30.3 versus 21.7, aldosterone 71.9 versus 60 was comparable, and diuretics also compared. So only statistical significance we saw between aldosterone antagonist and beta blockers. And beta blockers, the difference was statistically was very, very significant. And keep in mind, it makes sense, and it's a part of the practice. Milrinone acts by a different pathway compared to, is a phosphodiesterase inhibitor. So compared to dobutamine, which is a straight beta agonist. So giving beta blockers and beta agonists does not make sense. So when we did the 6-month Kaplan-Meier analysis, because as I said, the median time to death was 5.9 months, so doing 1 year would not make sense. So we did 6 months, and there was a statistical significance between the two groups, with a clear difference in the hazard ratio of death between Milrinone and dobutamine group. So once done that, we wanted to do as a good multivariate regression analysis as possible, taking into account the difference in their discharge meds, other comorbidities. So anything that in our univariate analysis, anything that had p-value 0.2, that's what we have been doing for a long time. So we try to include that in our model and see, is this a true difference or there is some other underlying reason? And when we did a multivariate regression analysis and took into account all the independent factors, we found inotropes did not make any difference when we adjust for beta blockers, ACE, ARB, aldosterone antagonist. It's the GDMT. It's the beta blockers that independently can predict survival with a good odds ratio of 2. Similarly, ACE, ARB 2.59, aldosterone antagonist 1.38. Ischemic cardiomyopathy patients do better than non-ischemics, and so forth. So what we found was, to summarize, that it's not the selection, it's not the agent itself, it's the use of GDMT at the time of discharge. So to conclude, in our study, we found dobutamine was a preferred agent over Milrinone in CKD patients. It was used in 43.5% of the CKD3 or higher compared to 23.5% of CKD patients. Among patients who had advanced heart failure, who were not candidates for LVAD or transplant and were discharged home on inotropes, there was a clear survival difference, with higher mortality in dobutamine group at 84% 1 year mortality compared to 58% in the Milrinone group. When we did the logistic regression analysis, inotrope did not come out as an independent variable of survival at 6 months, and beta blockers and ACE inhibitors were independent predictors of survival. And this use was at the time of discharge. I don't know if I mentioned that. So these were very two strong predictors of survival at 6 months. So with that, I will end the talk here. Want it to be as brief as possible, and we'll take any questions.
Thank you. That was great. I do feel like since working in heart failure, I've, always wondered why, because there's so much physician preference involved in the choice of the inotrope. And so that's always been a big question of mine. So the study was very helpful in kind of illustrating a lot of those things. How has this study impacted your feelings about the choice between these medications? Has it changed your practice at all?
Yes. So Milrinone is our preferred agent now, because same reason we can do better GDMT on the patients who are on Milrinone. And Rose, also, we make it a point, if they are not discharged on GDMT, we follow them on monthly basis, and we try to make sure that we put them on some GDMT and try to up titrate it as much as possible. Also, other research interest is more prospective studies need to be done. We first need to figure out, do inotropes help, and then which one is better, why we choose one or the other. It's difficult to tell from the chart reviews. And last but not least is, who are the patients who survive at the end? Because we did see 10% survive. How do we figure out up front and focus on these patients more? And should we do for the rest? Does it improve quality of life and all those? Even if they live 6 months, did it make any difference?
Well, and I think that is an interesting point, in that, when do you choose to utilize these inotropes? Because we often see them as the last tool in the toolbox. So when people are beyond being able to utilize GDMT, that's a lot of times during that hospitalization is when you see those medications be used in an outpatient setting. So I think that brings up a very good point. Do you use these in combination earlier, or do you wait until that person has exhausted all of their?
Absolutely. Yeah, absolutely. These are very fair questions.
Martin, you have a question.
Yeah, I got to say that I thought of Jerry when I was reading this paper, because I was thinking of the folks that do hospice. And when they're looking at these Kaplan-Meier survival curves, and they're going, well, I'm going to admit these patients to hospice because as a whole, they may have close to 6 months, but I wonder how this makes people, our colleagues in hospice, feel about admitting patients on Milrinone. If they're going to be pushing closer to 9 months or more, if they're more likely than not to survive a bit longer, is this going to make them better informed for who might be more likely to qualify for these services?
Yeah, it's a very interesting point. Very interesting point. One question I wanted to ask you guys, Rose, especially, what's your inotrope practice? How do you start patients on inotropes? Who manages that service? Is it quorum, or is it done by hospital?
It is advanced heart failure for the most part. But you will see general cards start the inotrope and then often consult advanced heart failure. But it is always the advanced heart failure team. When those patients go on hospice services, usually in order to get a hospice service to accept that patient, we say, we'll manage those inotropes, but the idea is we're not going to be titrating them. We're not going to be monkeying with those doses. And so that's kind of how it usually works. Or you have those patients, they think they're going to be able to wean them, and they can't, and they really are dependent
And what service do you use for their inotropes? Is it your local hospital? How do you manage these patients? Where does the inotrope come from? Is there
So I think there's specialty pharmacies.
from your hospital, or you are using
Both inpatient, yes, and then when they leave, the home care services or other specialty pharmacies.
Interesting. So we at KU have our own, so quorum. So there are two large sources of inotropes. One is quorum CVS, but I don't think we included those patients. It's difficult to get data, and we have very few patients. So we use our own pharmacy. KU has a program where we provide inotropes to them, and we have a home health service, hospice service, which is owned by the hospital. So that makes things slightly easy, and then they gain expertise also. And data like that kind of encourages us to do more, help these patients more.
Right. So there's a couple of questions in the chat. Sarah asks, even if not an independent predictor of survival, do you feel patients have a better quality of life, less symptoms, fewer hospitalizations when an inotrope's used?
So very, very difficult question. But I would say, I may be biased, but I would say yes. We have different providers in our practice have different preferences, but I always, if I am out of options, patient is in his 60s or even 70s, I would start on inotropes and see how they do, because I'm very aggressive in then checking if we can put them on GDMT and weaning them off. Can we use it as a bridge to put them on GDMT, wean them off? Because as I said, this was without any effort, without any real efforts or any GDMT escalation. 10% still came off. I don't know if they were less sick to start with. It's a very small group. We tried to work on that idea to look at these patients. It's a small group to draw any conclusions is difficult, but it's a good chunk. 10% is a good chunk. But we have to get better and kind of filter out first that should be the first preference on starting these inotropes. On that group, and then the rest.
Rachel says, we've had challenges with hospice accepting to pay for the inotropes. They insisted on using a non-heart failure end-of-life diagnosis and finally accepted, but it seems like a recurrent challenge. They're not really that expensive, to be honest.
You are right. But, we also have patients who cannot pay, and KU picks up. So it's not, you are right, it's not expensive, because I know a lot of patients are getting free inotropes from our pharmacy.
I wonder if it's more of an education piece.
Sorry?
I wonder if it's more of an education piece, because then you need extra training, comfort level with using.
You're right. And nurse has to go to their house twice, and that increases the cost to flush these lines and all those things. And we have gotten better with PICC lines. We do tunnel PICC line now, because experience has been they live longer than what we expected. They would come in the ER after 4 weeks, PICC will come out and all those things. So with time we are gaining that. But the bigger question is we need to do more studies. With these patients need to be studied more. We need to know if inotropes are helping, best ways to do it, who are these patients, how long do they live, what happens on quality of life, and they cross barriers and get advanced. So a lot of work can be done. It's a big population, as I said. It's like 95% of the patients who have advanced heart failure.
Jerry, did you have something?
Just to back to Marty's original observation question, and I think Rachel and Lindy did a great job of reinforcing there's a multifaceted reason why inotropes in the hospice setting aren't more accepted. We talked about cost, but they're not necessarily that costly, but the technical competence required. I think I use the term historical and cultural. It's not something that we do, and that's not necessarily a good reason. So I think it's all of the above, and I think conversations like this help continue the conversation and looking at possibly modifying practice. So I want to say thanks.
Thank you so much, all of you.
Yeah, I have to say, I have worked many years in conjunction with a lot of the different hospices to kind of educate and make it less scary. Because I do think there is that fear factor with a medication like this. And really, I mean, it is a palliative medication at a certain point in time for folks. It makes them feel better. And I think we've probably all experienced patients who we had to pull off these meds that you really didn't want to for whatever circumstances, whether it was going to hospice or they couldn't manage a complex regimen at home. And so I think when you experience a lot of that, you kind of dig your heels in when you're trying to get someone on hospice with these meds, when you really do see that they do make them feel better.
You're right. And I also want to bring last point is keep in mind the mean age was 64 years. These patients are not old. 64
Right.
is not old in this day and age. We are offering our oldest transplant last year was 74-year-old, and VADs are offered easily patients in 70. So these patients, by that comparison and how the longevity has is 64, these are young patients.
Right.
That in mind, these are young patients, and comorbidity profile is not that bad. So we should try. That's all I'm saying. I think it's worthwhile trying.
Well, I really appreciated this conversation, and it was a fun study to read.
Thank you so much, all of you.
Absolutely. Have a great day, everybody, and thank
You
you,
all,
Dr. Shah.
have a nice rest of the day, nice weekend. Thank you.
Bye.
Thank you, Marty. Thank you.